of whom are going to be represented today. So at Health Hub, we do four things. We throw events like this event today. Typically, we do them on campus. Obviously, right now we're not. So we're having this webinar series. We expect to have 7 or 8 of these. This is our second one of them. One of the other things we do at Health Hub is we connect entrepreneurs, founders, and companies with advisors and doctors and clinicians and folks that they feel are going to help them grow their business. And we've been doing this for now 2 years, and we have about 12,000 people who've signed up, either as members or followers of Health Hub. We also connect all these companies and these specialists to the experts at UCSF. These could be PIs. These could be companies that are seeking medical directors and expertise that folks at UCSF have. Among some of the events that we're throwing, we've thrown in the past, we've had events around reimbursement for entrepreneurs. We've hosted the delegation from Israel. We're going to get into our awards event. We have a series with Vader, and we throw typically an event or two a month. The event we're really excited about, besides this one, of course, is our second annual UCSF Digital Health Awards show. And we just opened applications today to companies to submit for to win for their health awards. Now, this event that we throw at UCSF is actually done in collaboration with a number of other organizations. Last year was a pretty big success, and this year we're really excited. We expect to have probably 750 different companies submit applications to be the biggest and the best of digital health. And we have 15 different award categories. We have 250 judges, a number of whom are actually on the phone today. And so for those who haven't signed up for the award show, please do. But today, we're not here for the award show. We're actually here for an event which is all about what happened. How did COVID change it all? And obviously, hospital systems like UCSF and others have been completely transformed. And we're going to hear about that today from our guest speaker and some of our moderators and some of the great vendors and companies that we brought in. This session today we have is really brought there 4 of our moderators. Ralph Gonzales, who will come up after us. He's the Chief Innovation Officer at UCSF Health. Daniel Kraft, who's the amongst other things, is the founder of Digital.Health. Paul Grant, who runs the incredible MedTech Innovator group, and myself. The guest speaker we have, and what a great picture that is Dr. Michael Blum. And you're going to have Ralph Gonzales, who will be taking over after me, will introduce Michael. We're going to go through a session with Michael. Michael's going to is a cardiologist, and he's going to be talking about COVID and how it's changed things. And from there, after Michael, we're going to hear from Daniel Kraft, we're going to hear from Paul, and then we're going to hear from our companies. And the companies today, we think we've picked 4 of the absolute best companies that are focusing on RPM, they're focusing on monitoring solutions in cardiology, Echo and AliveCore and Bardy and Entonics. These are you have 4 speakers, and they prepared a good 4 minutes to give a sense of what they've done. Then we're going to go into separate sessions where us moderators are going to spend some time with each of the speakers and allow you to ask some questions and to get a little closer to the companies. But with that, I'm going to turn it over to Ralph, and Ralph is going to introduce Michael. And Ralph, it's all you.
Hi, thanks, Mark. It's a pleasure to be here for the second event. The first one, which focused on remote patient monitoring, I think went extremely well. As Mark said, that where we sit at UCSF Health now, we're in a very different place than we were 3 or 4 months ago in terms of virtual care and remote care and how we're managing patients from afar, but also how our workforce is also working from afar. And so we're in a very different place now than we've ever been. And I think most people believe we're not going to go back to where we started, but in fact, we're going to create a new normal. And so it's a pleasure to introduce Mike Blum, who's going to be the guest speaker for the telehealth as it relates to cardiology and virtual care. Mike is the Associate Vice Chancellor for Informatics and also the Chief Digital Transformation Officer for UCSF. He's been at UCSF for almost 20 years and has been a major force behind the Digital.Health evolution at UCSF Health from its very beginnings. He led the EPIC installation and integration, introducing UCSF into the electronic medical records. He founded the Center for Digital Health Innovation, which has spearheaded major partnerships between UCSF and Samsung, Cisco, and GE. And he's also a board-certified cardiologist and a professor of medicine and continues to engage in clinical practice. So he really is the perfect person to moderate and introduce today's session. And so with that, I'm going to turn it over to Mike.
All right, thanks, Ralph. Appreciate it. Happy to see all you guys. I just have Mark gave me like 4 minutes, so I told him I'll take 12. And I just have a couple of slides to go through. So let's see how well this plays out. All right. Can you guys see my slides?
Yep.
Okay. So as Ralph said, we're in a different world. We've been transformed by this pandemic. You know, we won't get into all the other stresses that are going on right now, but it's pretty clear that care delivery has changed. I'm going to show you a little bit of the impact of that. But no one's anticipating that we're going back completely to where we were. Where we end up is not clear, but the patients are enjoying, I think, the ability to see us in very different ways, and we're not going to be going back to the old model. So this is actually all UCSF and Zoom. So in case any of you are feeling like you're spending a lot of time on Zoom, turns out that you are. In the month of May, UCSF staff spent almost 58 million minutes in Zoom meetings. So everyone is shifting to video, and all of our lives have been impacted by it. This is data from our primary care clinic on the impact of COVID and what happened with volume. So the purple is the historical in-person visits. And this starts in the beginning of March. And you can see our baseline there in the primary care clinics was about 600 visits. And we do at UCSF, you know, around 8,000 visits a day. But this was just the primary care volume in that. And you can see the purple line was decreasing as the pandemic was really getting going. Shelter in place is that green arrow there. And that's about when the nadir of the visits happened, and we had gone down to about 63%. Some clinics were around 50% of their volume by that point. But what you notice is the green bars is the uptick in video visits at the same time. So we had been working at about 1 to 2% of our visits were video visits before all this. And then there's just incredibly rapid transition. As you can see, the decimation of the in-person visits and this rapid growth in video visits, which on one hand was excellent because we were able to provide some care to our patients and stay in contact with our patients. But what you can see is several things is throughout this period, the in-person visits didn't come back. There was a significant amount of telephone visits, which is the yellow bar, but the overall totals hasn't gotten back to its baseline. We're starting to see that now. My cardiology clinic broke through its baseline about 2 weeks ago. So we're back to our full number of visits, but still the majority of those are video visits. So whether this, how much this changes when we eventually come out of shelter in place and people can travel, it's pretty clear that it's not going to go back to where it was with the all purple, but it'll remain with some significant portion of the green. So that's pretty good. This is what our exam rooms used to look like, and typical equipment in the bed to examine the patient, a bunch of computers that we sat at, tried not to have our backs to the patients, but we sat there and did our charting and our exams and acquired all the data we needed. The exam rooms now look like this. It's all of us sitting either at home or in an office somewhere by ourselves with a computer, talking to the patients either via video link or on the phone. But we are significantly separated from our patients, and for the most part have no ability to really touch them or interact with them other than electronically. So the problem that creates is when we do our visits with them, you get this blue highlighted bar that's part of the note. No vitals taken for this visits. There were no vital signs acquired. So as a cardiologist, vital signs are kind of important to me. They're, arguably the most important part of what's going on until I get to the exam. And then you get to the exam, which is right below that. And in that, yellowish mustard color there, they're pretty important parts. I can still see their neck veins when I look at them over the video, and I can get an estimate, which is important for my exam. And I can hear how they're breathing. I can watch their respiratory rate. I can see if they're struggling, but I can't listen to their lungs, which is, again, one of the most critical pieces as a cardiologist of assessing these people. Their heart, same thing. I can't do anything with their cardiac exam. It feels fairly emasculating to have to be a cardiologist who can't listen to a patient's heart while you're trying to provide care to them. So while it's better than not seeing these people and having no idea what's going on, it is clinically insufficient. And while video exams are great and we're getting paid for them, it is no way to be taking care of our cardiology population. So we're in this interesting time where we have a plethora of devices and great technologies. We heard a lot about that last time. We can monitor remotely, just about every parameter. And I've been very politically correct here and not put any names of devices on, but we certainly have great ability to look at, heart rhythm, heart rate, blood pressure, pulmonary artery pressures, listen to hearts, use ultrasound equipment. The technology out there is fantastic, and I've talked about it for years about the transition that it's creating. But the reality is I'm still sitting here looking at a computer monitor and trying to figure out how we make those first baby steps into using these devices in the clinic. And it's not as though we're at some ridiculously backwards place. The vast majority of places are just putting their toe in the water, if they're even at the water, of how to use these remote monitoring technologies in a scalable way to take care of the patients. So it's a very uncomfortable situation where your patients know these technologies are out there, but they're not in the clinical domain in a way that we can say, yep, here it is. This is how we're going to take care of you now. So the reality is there are a very limited number of deployed solutions that could rapidly scale in this COVID era that you can just grab, get out to the patients and have fit into a clinical workflow. A lot of that is because the cost and the effort to integrate the solutions with the electronic health record is huge. Our clinical systems team, which has deployed one of the leading health records in the country, is consumed with battling everything to dig out of the financial hole that the pandemic has caused. And they have very little bandwidth to start integrating, a whole bunch of new sensors and remote patient monitoring. You could argue that should have happened before, and that's a whole nother discussion, but we are where everyone else is. It hasn't happened for the most part, and the ability to integrate that now is really limited. And then integrating it isn't just dumping a whole bunch of data to the providers. You have to build workflows around that meet the needs of the providers and the administrative staff so they can actually use this new data. And no one's got money right now to spend on new solutions to really address these issues. We were looking initially at a $5 million a day hole. It's now down to less than $3 million a day, but those things get real big, real fast. What did I see? I saw Providence, in the last month lost over $1 billion. And these numbers are huge. No one's got money to spend that's net new on these kinds of solutions. So the solution that we want to see is SaaS, and that's not software as a service, that's a solution as a service. So what we're looking for is vendors, partners who have ready to deploy all, clinically validated solutions that can plug these holes that I'm addressing, that can deliver blood pressure, heart rate, pulse oxygen, heart sounds, lung sounds, and then get more sophisticated into ultrasound examinations, and all of the other modalities that you guys know about and are working in. But not just to say, hey, we got one of those and we know that it technically works, but to be able to deliver it to an organization as a service, so that I can take it in, I can say, this is already either this is how you integrate it, or this is how it works as a standalone to meet the needs of the provider, but it is actually usable in a clinical care provision scenario. And again, the cost of these things, you can't be looking at what is a nominal reimbursement for a visit and say, well, we're going to throw on another $100, $200 worth of cost onto the visit to provide the service. So realize that it's a big ask, but that's where we've gotten to is we're providing care and we need this data to do it. And we need your systems to be able to help out. So I think that the big opportunity here is that there are now new payment models that are going to support the remote care in ways that we've never seen before. Apologize for the eye chart, but the reality is Medicare is somewhat stepping up. These are all numbers for remote management, chronic management, remote monitoring, and they're all small dollars. They're all, almost all of them are less than $100 for up to 60 minutes of work. But the point is that this is the first time that Medicare is actually stepping up in a way that gets close to a usable reimbursement. And if you add this over a significant number of patients and you build a program around it, this could be effective and is certainly an offset to any new costs that these devices are going to create. And the much better news is that the private payers are paying multiples of this that actually can make these programs stand on their own. So I think that the takeaway and the challenge for you guys is that you've got to not only have tech that's working incredibly well, reliably, and validated so that we can believe what we're seeing and the numbers we're getting, the sounds we're getting, the pictures we're looking at from your technology, that's kind of table stakes. If that's not there, no one's going to talk to you. So that's all got to be there. But then we've got to take the harder leap to this now needs to work very quickly on very short notice in a clinical environment, incredibly cost effectively. And that probably looks like a coordination where we tell you who the patients are, you send out a package to them that you then set up and ensure the connections and share in the reimbursement off of that, so you guys get paid for doing that. We do the monitoring and the activity, or you do the monitoring, we do the clinical activity, and there's enough in there for everyone to take care of patients in this new model. So I'm going to stop there. I learned a long time ago, never go before or after Daniel Kraft, because it always makes you look like a rookie. But I think he's next up to tell us how this is going to all work much, much better.
Great. Thanks, Michael. Hey, I'm Daniel Kraft here from the Peninsula, and honored to be taking part in version number 2 of Hospital to Home. And I'm going to take about 10, 12 minutes to kind of recap some of what we talked about in our first session 2 weeks ago, but kind of try and cover things that particularly relate to the future of health and cardiology specifically. The theme of these series have been sort of hospital to home or homespital. I mean, clearly COVID has been catalyzing, as Dr. Blum mentioned, virtualized care. We do have the opportunity in this crisis, and crisis in Chinese also translates to decision and opportunity, to unsilo and reimagine many elements of healthcare. That's been certainly catalyzed. I always love the theme of moving from sick care to healthcare. And just as a reboot, we do live in this sick care model based on intermittent episodic data, usually only collected in the clinic or the ER or the ICU, whether that's an EKG, your blood pressures, or challenging abilities to communicate your blood pressures or blood sugars, or your digital exhaust. And that leads to our reactive sick care model, where patients tend to show up in the emergency room with their heart attack or their stroke or I'm an oncologist with late stage cancer, or come in with an infectious disease, or as a society and world, we wait reactively for a pandemic to arrive. And the meta potential, particularly in cardiology now, is to leverage all these new emergent tools to be much more continuous with the flow of information, whether it's from our hearts, our behaviors, our environments, be more personalized, proactive, and ideally start to bring care anytime, anywhere at much lower cost, which will really democratize healthcare around the planet and bring care to more people more effectively. We also really practice imprecision medicine. For the top 10 grossing drugs prescribed in the US last year, they only were really effective for about 1 in 4 to 1 in 24, including drugs like statins. So how do we get more effective about picking the right drugs and combinations for the individual based on their genomics and other risk factors? Lots of potential to improve, to sort of move the needle proactively, including on optimizing our health, precision wellness going forward. So thematically, of course, in our exponential age, what used to fit on your desktop now fits on your Apple Watch. Or Apple Watches and wearables are becoming FDA cleared devices, can clearly now do EKGs and beyond. They're integrated into our Internet of Medical Things, riding 5G, creating massive amounts of data. And as Michael mentioned, the challenge is how do you integrate that into the workflow of a clinician? It's not just about the data. We don't want the raw data for most of our patients. It's how we put it together. We're seeing the corner pharmacies become instant players, leveraging telehealth to be battling it out for primary care and diagnostics and therapy of the now and not so distant future. And of course, all this rides the rails of what we're calling digital, connected, mobile health. I think we'll soon just call it health. And we are now studying this. It's not a panacea to give someone a connected blood pressure cuff or a Fitbit, and to understand how these technologies work in the real world and to learn from them to change how we're doing care. So that's all about convergence, and that's digital meeting AI, big data, 3D printing, nanotech, and beyond. And I always love to emphasize this slide. We're getting new amounts of digital data, but we need to turn that into information and narrow the gap between that new knowledge, whether it's how to manage or diagnose or treat a COVID patient, or manage myocardial infarction or heart failure, and to narrow the time between the best of class knowledge published in a journal ending up in our hands at the point of care. Also, a key point to mention, particularly as it's so impactful in the era of COVID, we know our social determinants are much more impactful than our many other elements, including our genetics, including our risk for COVID and our outcomes. Our zip code's more important than our area codes. So we need to pay attention to those social determinants, how they play a role in our cardiovascular health, or our epidemic of obesity, which certainly plays a role in cardiovascular disease. How do we, since I'm training pediatrics as well, catch our kids early, giving them whole grain foods when they start eating at 6 months of age, which changes their gut microbiome and lowers the risk of diabetes and obesity downstream. So lots of things we can do early. So paying attention to the core elements: vaccination, clean water, social connection, and beyond. Of course, our platform, our base needs are getting evolved in these days. Of course, our number one need these days is battery life. So if we can fix that one. Okay. Otherwise, we can now use some of these connected tools to really impact our cardiovascular health behaviors, particularly our bad behaviors: poor diet, a lot of activity, stress, smoking, et cetera, lead to significantly contribute to our cardiovascular disease. 15, 18 years ago, I was doing work with NASA. We built this black box for the body. That was one of these early quantified self devices. Clearly now we have an explosion of wearables and beyond that are enabling us to collect almost every element of physiology and behavior. And what we're starting to see, particularly catalyzed now, is moving from the quantified self-siloed data that's stuck on your phone or your app and connecting that to your healthcare provider, quantified health, to enable us to be smart about personalized proactive prevention, doing earlier diagnostics, whether that's atrial fibrillation or cancer, and then for therapy to have a smarter feedback loop. And of course, we have lots of new tools to digitize. You cannot just measure your weight. This is a startup doing your shape, which can measure your fat content and muscle mass as well, which might change how you dose the medication or look at someone's changing heart failure parameters with edema. We're seeing ways of doing seamless blood pressure, built into watch bands, or just approved last fall, the versions that can just use a patch, now FDA cleared by Beats, out of a patch or a wrist-based element for 24/7 blood pressure monitoring. And hypertension is the #1 cause of early death and morbidity around the planet. Invisibles, the idea that our smartphones, our cameras can pick up signs, vital signs, temperature, heart rate, maybe even blood pressure, are going to give us these new sort of continuous ways of tracking our data 24/7. Now, Voice, of course, can be even a biomarker for this, picking up heart disease by the sound of your voice, or other elements. Bottom line, many new ways of collecting data. The trick is, how do you make it truly predictive and personalized? The idea of predictalytics. Verily is doing the baseline trial, the All of Us trial at NIH, collecting digital exhaust, genomics, medical records from thousands of volunteers. It's gonna help us make sense of this data outside of the four walls of the clinic. Or use our smart devices to give us that kind of check engine light element. You know, in this case, if someone has a fall, can call 911. Or Mike Snyder at Stanford's sort of pioneering the idea of this sort of check engine light, integrating metabolic data, wearable data. He picked up his own diabetes and Lyme disease from this sort of information, and is taking that a step forward with a startup called QBio. Thinking about, how do we think about that physical of the future that can be done at home, as well as with fancy imaging and other elements. So you get your own sort of synthesized digital twin dashboard that's really always evolving and tuned to you. I had a similar approach done. I went through a full body MRI in Vancouver, a company called Pronuvo. Amazing amounts of data you can get back in an hour MRI, and they're now using machine learning and AI to analyze the data. And I get a pretty complex report from me and my clinician to be hopefully proactive with that information. And it's of course not practical for everyone to get an MRI every year, every 10 years, but I think that's going to accelerate. You may walk into your corner CVS in 10 years and literally have a 10-minute MRI scan. We're seeing the advent of smaller, cheaper MRIs, hyperfines rolling out as of this month, 20 times less the cost of the standard MRI. We'll see for the head, but again, new ways of imaging or new ways of training. Simulation is coming to bear. Companies like OSO-VR focus on orthopedics, but we can see this probably training the next generation of cardiac interventionalists beyond going forward. And of course, we can use VR, I think, in powerful ways to learn about the heart. This is the Virtual Heart Project out of Stanford. So peds cardiology fellows or families can understand the complex congenital disorders their kids have and maybe have new ways to manage them. Somehow my slides get out of order here. I love this new one out of Israel, oxytone. It's the first, I think, FDA cleared for doing pulse oximetry, which is particularly important maybe in managing COVID patients. So lots of new wearables are out there, shockables, ringables. We can even start to quantify our food. Hippocrates said, let food be thy medicine, medicine be thy food. You can start to track that input, output. And I think the era of personalized nutrition is going to play a super important role in cardiovascular health, or even reversing heart disease, as Dr. Dean Ornish and others have demonstrated. So somehow my slides get a bit out of sync here. I think what gets super interesting here is, again, what we can already do with our existing devices. Just using my Apple Watch now and an app called Heart Watch, I can pull out incredible amounts of data about my resting heart rate, my sleep rate data, my HRV. I'm just scrolling from my phone. Look at my exercise and my ability to recover in what time. So my sleep data, all that is intensive amounts of information. What if my resting heart rate is going from 58 to 78? What is that going to mean about proactively predicting a stroke or a heart attack? I think that'll be, again, part of our dashboards going forward. And we'll start to increasingly integrate that and share that information, sort of high precision maps of health that we'll share. And then when we know about our risk, we'll hopefully leverage smarter digital avatars and coaches to help us with our wellness, but also help us in managing complex cardiac diseases and beyond, to give us that kind of humanized touch as we move forward. That's coming to our voice-based platforms, lots of things coming to Alexa and Google Home. It's going to come to our mirrors when we can have personalized coaching. It'll give us an insight into not just you of today when you look in the mirror, but future you. You know, what happens when you are eating, 10 Dunkin' Donuts a day, and I love my Dunkin' Donuts, but I'll stick with one because I don't want to end up like this. So new ways of kind of getting insights into our future. And that, I think, can blend with the convergent world of augmented virtual reality, enabling the interventional cardiologist or surgeon to pull complex data and use that at the point of care, or to show that to your patients. If you can show them about their asymptomatic disease, that they have, carotid disease, that gets them more on top of their medications. Or you can take your kids with a simple app called Virtuality and kind of educate them about their basic anatomy. It's a pretty fun virtualized platform, so you can learn about basic cardiac function and blood and lungs. Here's my son Leo when he's 3, learning his anatomy. So get him while they're young. That can change perceptions and understanding. And then there's platforms out now like AnimaRes, where I just recorded this today. If it's going to play in my office here, you can basically bring up your human avatar or anatomical guide anywhere, learn your basic anatomy, or more complex if you're a medical student, pull up the heart and do a little bit of a cardiac anatomy lesson. Let's see if it works here.
Normal heart rate. Now take a look at this healthy human heart beating at a level of 80 beats per minute. A normal heart rate is defined by 60 to 100.
So you get the idea. All those are possible today. Or virtual reality, which is fun to program on a roller coaster. And I've got my Oculus Quest here. These are getting cheap and available. They're being used in all sorts of ways for therapy, for pain, or folks who are in the hospital about to have a procedure, go to a relaxing environment, to start doing virtualized yoga or virtualized meditation. I've been addicted this last month on my Oculus Quest to this new game called Supernatural, where I've been doing every day daily, get my heart rate up to 150, 160 in a sort of virtualized environment. So this is the future of cardiac rehab or just doing daily exercise as well. So if you have an Oculus Quest, try this out. Link to me. We can be exercise buddies. Pretty engaging. And I already mentioned some of the training tools that are out there. I'll finish up with diagnostics. Lots of new ways that are out there. I mentioned the digital doctor bag is here. I think we're going to see and hear from AliveCore and others about the new ways these are being used to do early diagnostics or maybe even pick up signs of COVID. We'll hear from Echo, blending AI, machine learning for home diagnostics and to augment the clinician. And we're starting to virtualize diagnostics. HeartFlow has pioneered the idea of the virtualized angiogram using computation in the cloud and a relatively fast CT scan to pick up coronary disease and then hopefully triage patients smartly. So lots of new ways we're going to blend this further. And of course, the important layer of personalized genomics, particularly the low-hanging fruit of pharmacogenomics, what statin is most appropriate for a patient, how do we just understand disease at the genetic level, how do we start, particularly in the cardiac world, understand, I think we'll all be sequenced in 5 years for less than $100, your risk for heart disease, AFib, and other issues, and that will be part of your proactive care platform going forward. Of course, we need to make these genetic databases more diverse going forward as well. And of course, the microbiome plays a role. I'm running out of time. To synthesize all this, we have a challenge, right? It's overwhelming amounts of data. AI, machine learning is playing a role. We're starting to see, looking at the back of your retina can predict risk of heart attack and stroke. We've seen the advent of startups now get FDA clearance for replacing the cardiologist to measure cardiac function. All sorts of new things are coming to bear, including AI-based EKG screening to pick up evidence of left ventricular issues and beyond. So lots of things are going to come together and become integrated into the clinic. It's not going to replace the cardiologist or the doctor or the nurse. It's going to sort of blend what humans do well, common sense, dilemmas, compassion, with what AI machine learning can do in combination. So AI is not going to replace the clinician, but the clinician using AI will replace those who don't. And increasingly, you can upskill the nurse practitioner, the community health worker, and techs and others to do what standard docs and even cardiologists can do, and maybe even turn your doc into an avatar. I've been building a platform called Digital.Health where you can start to explore the tools that are out there today, the solutions, the apps, and hopefully we'll have a platform like that to do personalized digital health formulary going into the future. And finally, we can apply all these lessons to hopefully pick the right cocktails of medications and preventive tools for preventing heart disease if someone's at risk, or instead of taking aspirin, statin, beta blocker, Synthroid, vitamin D, and 3 hypertension meds, build your personalized polypill. So that's a platform I'm building out called telemedicine, where I think part of this future of cardiology is that one pill that fits you and adapts to you based on your metrics. So with that, I'll just close that the future of health, medicine, and cardiology is exciting. It is moving from hospital to home. It's this convergence in many fields. We all need to think exponentially and skate to where the puck is going because it's moving faster and faster. And I think together as a community through UCSF Health Hub and beyond, we're creating that smarter, better, proactive future of health and medicine. So with that, thanks, and I'll turn it over to Paul Grand.
Very good. Thank you, Daniel. Once again, just about 3 hours of content in 10 minutes. So awesome. Thank you, Daniel, for that. So one of the things that I'm going to do very quickly is just tell you about myself. I'm Paul Grand. I'm the CEO at MedTech Innovator. I was an entrepreneur, started 8 different companies, then became a venture capitalist at a firm called RCT Ventures for 12 years. And about halfway into that time, I started MedTech Innovator as a program that was designed to help find and to showcase some of the leading companies that we found emerging in the MedTech space. That was one of the things that I started doing as a side gig, and it turned into my full-time job. So we spun MedTech Innovator out in 2016 as a standalone company, and I run that now. I'll tell you a little bit about MedTech Innovator so you can learn more about a little bit of context for that, and then we'll get into the company presentations for today. So very quickly, MedTech Innovator is a nonprofit who's focused on finding the technologies that we think can really make a difference in improving outcomes, lowering cost, safety, et cetera, for patients, and making sure those companies are successful. We're an accelerator, but we're not a traditional accelerator. We don't have a physical location. This is a virtual program, a partnership of the industry. What you see on the screen there are the pictures of the products that our alumni have brought to market and the graduating class in front of that of 2019. We're about to announce, we're about to select our companies. We're going to make announcements tomorrow to the startups that are going to be part of our 2020 cohort. So things are pretty exciting here. And we're going to have a new group of 50 companies that will be part of MedTech Innovator 2020. We're very good at what we do. We have 258 companies that have been through the program, 54 products on the market. We're just closing in on $1.7 billion in follow-on funding with some of the announcements of this week and some of the startups that are part of our alumni portfolio. But the most important thing is that alumni group, because MedTech, digital health, et cetera, is a space that is pretty disconnected, especially these days in the COVID era. People are working in a pretty isolated way. And with the exception of coming to scientific meetings or some of the conferences like this, people are pretty disconnected. And so what we've created is a platform where people can actually work together to advance their technologies and do so with industry. One of the things that we hate is to see startups fail, to see companies that should be successful fail for the wrong reasons. I put out an article a couple months ago with my COO, Catherine Zavala, on why healthcare startups fail, and specifically things that are in your control. So you can Google this, you can find it. We'll put the link into the chat so you can look it up as well. But there's 10 reasons we give for perfectly preventable things that you have in your control that you can do to avoid failure. So we really don't want to see you fail. Please take a look at that. So my contact information, well, kind of my contact information, my @MedTech Awards, that's MedTech Innovators Twitter handle. Mine is @LifeScienceBC. And MedTech Innovators website, you see down below, medtechinnovator.org. If you're interested in learning more, I encourage you to go there and reach out to us, because we're really trying to make sure we find the best startups, the best emerging companies. When I say startups, I mean companies from very super early stage all the way to companies that are in the market, that have products on the market, that are serving patients, that are serving consumers in some cases. We serve all customers. We're talking about anybody that's not a large cap medtech company that's kind of accessible to MedTech Innovator. So what we've been doing in these events is we've been featuring startups in this hospital to home space. And I say startups again, these are companies that are, these are leaders in the space. These aren't companies that started yesterday. These are companies that have been at it for quite a long time and are successful and are validated. And I think that's the important thing, is we're looking for validated technologies that we can bring to you so that you can learn about them, you can understand how to access them, you can get in touch with them. This is all about connecting with these companies because at the end of the day, that's what it's going to take for you to be successful in whatever you do, whether you're an investor or a care provider or another company that's emerging in the space. You need partnerships. So I encourage you to reach out to these companies. We'll have breakout sessions that'll follow their presentations where you can connect with them. And if you don't connect with them in those breakout sessions, you can also connect with them after this event. They're going to have their own private Zoom chats that you'll be able to join as well and get to know these companies a little better. And in general, their contact information will be made available to you. So we encourage you to reach out to them, to connect with them. We've got 4 tremendous companies here that are in this cardiology space for remote patient care in some way. It's one of the things that we're really excited about. Obviously, COVID has been a horrible thing for all of us to go through, but one of the great benefits that has come out of it has been this real surge in remote care and the adoption of technologies in that space. So we're going to have 4 companies now give you very short presentations, 3 minutes each. You'll get to hear a little bit about what they have to offer. And then again, you'll have an opportunity to talk with them in depth in one of those breakout sessions afterwards or in their private breakouts. So with that, we're going to go in alphabetical order here. We're going to start with Dr. David Albert from AliveCor, one of the pioneers in the space of mobile technology and delivering care for patients outside of the clinical practice. one of the things that we're really excited about, again, is to bring you leaders, and Dr. Dave is one of those. So I'm going to stop sharing my screen, and then the others will follow after that. I'll introduce each of them, but I'll let them introduce themselves actually as part of their 3-minute presentations because we don't have a lot of time. So Dr. Dave, it's your show.
Thank you very much. I'm Dave Albert, and unfortunately, I can relate to Mike. He has some gray hair. I'm one of the old men of Digital.Health. Started AliveCore about 10 years ago and pioneered the notion of direct to patient personal electrocardiography. And we today have in our cloud somewhere in the neighborhood of 75 million ECG rhythm strips spanning 10 years. UCSf has, we supplied them thousands for Healthy Heart, and I would say most major medical centers have patients who are being monitored by AliveCore. And so you may be familiar with our Cardio Mobile device, which has undergone all the way from an iPhone case to the current Cardio Mobile, kind of a stick of gum size, to our new Cardio Mobile 6L, which is a 6-lead ECG, providing half of the 12-lead ECG, what we call the limb leads. And so we have over 90 peer-reviewed clinical validation papers in every major cardiovascular journal. And that's the result of being old and been around a long time. What is it used for? It's used today all over the world for remote patient visits. So whether they are asynchronous, a patient has a symptom, records an ECG and sends it, or whether it's synchronous, and I'll get into that in a second, we bring in cardiac rhythm and have developed a portal called our Cardio Pro portal, and actually have interfaced it to Epic. I won't go into that pain, but at places like Cleveland Clinic and Cedars-Sinai, they have a Cardio Pro interface into Epic. And we've partnered with a company called Omron. If you go into one of your drugstores, you'll see their blood pressure cuffs, so that you can send both rhythm strip data and blood pressure data, facilitating a cardiology televisit. And as a matter of fact, these are screens from Cardio Pro that a physician would see. What you see on the top are the trends, the color codes, the rhythm. And you can see on the left in the middle area, you can see blood pressures where we code, again, by color, whether or not you are stage 1, stage 2 hypertension or normotensive. And so you can zoom into any one of these bullets and see the exact rhythm, but it gives you, of the clinician, a view of what has been going on with my patient since the last time I interacted with them. Again, any one data point to me is not nearly as important as the first derivative of that data stream. Is the patient getting worse, or are they getting better? And as a matter of fact, my friends at the Cleveland Clinic, who've been a long-time user, Dr. Khaldun Tarachi, who's the assistant chief and head of their digital health innovation efforts, has a paper in press called Use of Virtual Visits for the Care of the Arrhythmia Patient. And that's been published online. And this talks about the value. So at the Cleveland Clinic, they had 4% virtual visits. And obviously, they're a big referral center where people fly into Cleveland. One of the only reasons you'd fly into Cleveland. And now they went up to 75% because, again, many referral patients. And so what you can see here is tremendous acceptance of that visit. Now, obviously, until recently, this paper was done before Medicare started paying full price, that is in-person visit rates. And so that was the one area where people were complaining because Cleveland likes to get paid, as does anybody. But other than that, both the physicians and the patients really enjoyed the televisits. And I think this is what Dr. Blum mentioned. We're not going to go back to 3%. It's going to be something more than that. And in cardiology, having the rhythm, having the blood pressure, these are important things. And so with that, I'll send it off to the next person. But with the notion of clinical validation, business model validation, These are critical elements if you're going to get your product and service accepted. Take it away.
Excellent.
Let me stop sharing here. There we go.
Thank you, Dave. Tremendous technology and great presentation. So please visit his breakout room either randomly or intentionally after this when you get the link. The link is in the chat. All right, next up, Connor Landgraf from Echo Health. So Connor, if you want to queue up your slides and start your slide share. So Echo Health has got a tremendous technology in terms of virtual stethoscope. You're going to hear all about it now. So Connor, take it away.
Thanks, Paul. Can everyone hear me okay? Hopefully I'm unmuted. Yeah, at Echo, our mission is to use data to improve the detection and management of cardiopulmonary diseases. Our specialty has been in using heart sounds and lung sound data, basically acoustic data, to help us better understand the mechanical function of the heart and the patient's lungs. And we turn a stethoscope exam, a traditional, auscultation exam, into a powerful remote patient monitoring tool. We've got a series of both devices, mobile software, and then now AI FDA cleared algorithms to help screen patients for cardiac conditions, including heart murmurs associated with valvular heart disease, and now AFib detection. We have 2 generations of devices. The first one there is the core, and that's it's a combination, or it's a digital stethoscope device that's able to stream the patient's heart sounds to the mobile software that accompanies the device, and then can actually conduct a real-time televisit for that patient. And then we have the Duo, which is the first mobile combined digital stethoscope and handheld ECG device. And so it's possible for the patient to capture simultaneous ECG and heart sound tracings, giving us both the electrical rhythm and the electrical performance of the heart muscle, and then the mechanical performance and the opening and closing of the patient's heart valves as well in simultaneous synchrony. So you can actually see the rhythm strip and what we call the phonocardiogram, the audio waveform, in real time on the same rhythm strip. And then we've gotten a series of algorithms FDA cleared as well to do heart murmur detection that's often indicative of congenital or valvular heart disease, AFib screening, and then just basic detection of bradycardia and tachycardia. We've built a number of solutions along with this, so we can power real-time synchronous transmission of heart sounds, lung sounds, and ECG data alongside video visits. So I'll show you what a screenshot of that looks like in just a second here, but it's that synchronous transmission of both of those data streams while the actual video visit is occurring. And that allows the clinician to guide the patient through maneuvers, allow them to inhale and exhale, allow them to guide the patient through that exam as if they were virtually there. And we obviously are in complete agreement with Dr. Blum that it's pretty hard to do and in care for cardiac or pulmonary patients without being able to do a vital sign exam and being able to capture that data. And then we provide in-clinic screening and monitoring services as well. This is just a basic screenshot of what our virtual visit software looks like. So it provides camera and video conferencing in real time, and then overlays on top of that the ECG rhythm strip, and then the phonocardiogram and heart sounds or lung sounds associated with that. And we've been in this kind of real-time telehealth business for a number of years now. Our largest customer deployed with us has more than 3,000 patients being monitored at home with our devices, and we've seen some really successful deployments of telehealth and virtual care models. And it's been really exciting to see the ways that the new incentive structures to encourage and pay for and allow clinicians to be paid for the time that they spend doing virtual visits with their patients is encouraging telehealth adoption. And I think we're in complete alignment that it's not going to go back down to 2%. And that we're able to then have more touch points, more convenient, less friction visits with patients that allow us to provide better care, more consistent checkups and follow-ups, and be able to provide as a result of that, hopefully, better outcomes and more consistent monitoring for patients. So I'll turn it back to you guys now. Thanks.
Thanks, Connor. Really interesting technology. Again, if you look down in the chat, there'll be a link to their virtual social after this. So you'll have a chance to talk to Connor, Dave, and the others and learn more about their technology and their companies. All right, next up.
Just a real quick color
yes,
commentary. It's Mike.
please.
So one thing that just for the group is, I would say that the biggest increase in complaints, aside from all the usual chronic patients that we see, is an increase in atrial fibrillation and palpitations that's gone along with the pandemic. Those are those atrial arrhythmias are very sensitive to stress and to poor sleep and more alcohol and less exercise. And I would say about 10 to 15%-ish of my increase in scheduling volume is driven by all these arrhythmia questions.
Excellent. Thank you. Thank you, Michael, for providing that color commentary. And you're welcome to do that for each one of these as well. All right. So next up, we've got Ken Nelson from Barty Diagnostics. So Ken, if you want to bring up your slides. Ken is the Chief Commercial Officer, and he will tell you all about the Barty story. So go ahead, Ken.
All right. Can you hear me okay, Paul?
Can, yes.
All right. Just wanted to start out by saying I think you guys picked some really amazing, innovative companies that really complement each other. If you think about Echo and AliveCore being used earlier in the care continuum to really identify patients with potential issues. And then if the physician thinks the patient may have heart failure, using the Endotronics technology, and if they have an arrhythmia and want to look at more extensive monitoring and looking at burden, heart rate variability, different trending, they'd use the CAM patch. I think they all complement each other really well. For us, my name's Ken Nelson. I'm Chief Commercial Officer for Barty Diagnostics. Barty Diagnostics is an innovator in remote patient care and cardiac monitoring. And our initial focus has been on providing the highest fidelity rhythm strips, most diagnostically accurate reports, and most patient-friendly monitors in the industry. And our CAM patch is a single-use disposable up to 14-day cardiac monitor. And when people ask, how are you different? Why are you guys so passionate about this? It all starts with our founder, Dr. Gus Barty, who's been an electrophysiologist for almost 40 years now, the inventor of the subcutaneous ICD, lead investigator, Scud Heft. He's got 276 patents to his name in cardiology and EP. And ironically, his own wife wore 10 different external monitors, had 2 different implantable monitors, none of which could clearly identify what type of rhythm disorder she was having. And so unfortunately, at the young age of 52, died of sudden cardiac death. And you can imagine being an electrophysiologist and fighting that arrhythmias your entire career, trying to prevent sudden cardiac death. When that happens to your own wife and none of the monitors that she wore could identify the rhythm that she was having, this had a tremendous impact on Dr. Barty. So a year to the day after her death, he started Barty Diagnostics with the mission of really developing the new standard of care in cardiac monitoring. The problem in the industry is really around a number of different things. Rhythm fidelity and diagnostic accuracy has historically been one of the bigger problems in terms of noisy recordings, false positives, really just not optimal ECG recordings. From a patient-friendly standpoint, the wires, the complexity of these monitors just were not ideal for long-term monitoring. And then iRhythm came out initially with the patch technology, which was really good in terms of a technology that would improve patient compliance, but didn't focus on diagnostic accuracy and rhythm fidelity. And so that's what Dr. Barty spent most of his time doing, is really focusing on rhythm fidelity and how do you get there. And so our proprietary hardware design includes patented circuit board design, signal processing, and then you combine that with several other factors, including sternal placement on the chest, and that gives us the ability to capture low amplitude, low frequency signals. And for us, we really focus on 3 different areas. We feel like there's 3 different products for 3 different customer types. The patch itself is the product for the patient, and we talk about comfort for the patient. The back-end system, which we call BDX Connect, is really the product for staff. And so you think about convenience for the clinic, and then clarity for the physician. That's where the reports come in. So think about the high fidelity strips, and then the actionable, accurate data that would be on a report that's looking at 14 days of continuous monitoring of ECG. And so for us, in terms of the COVID environment, we rapidly transitioned to sending our monitors directly to the patient's home. So combining that with a telehealth visit and a single-use device that doesn't need to be reused again, really an ideal technology in this environment. In terms of compelling clinical evidence, there's been a couple head-to-head clinical trials that have been done. One versus a traditional Holter monitor, where physicians found 4 times more arrhythmias, and a second versus iRhythm Zio patch, where physicians found not only 40% more arrhythmias, but they also would have made a different clinical action in those patients based on the arrhythmias that they found with the CAM patch. As an example of that, this is one of the strips. And again, patients were wearing both patches at the same time. On the left-hand side, you see that they found atrial fibrillation. On the right-hand side, same patient wearing both patches at the same time. Clearly, you see flutter, you see AFib, and you see atrial tachycardia. So 3 different arrhythmias, whereas iRhythm only identified 1 on that patient. And you can see a much clearer picture of the arrhythmia. And then I don't know if you can see my pointer, but if you look at this 40-minute R-to-R plot, you can see you've got flutter that goes into fib. This shows onset and offset of the arrhythmia, and that's something that's patented on our reports. So in the interest of time, again, we're focused on comfort for the patients, convenience for the clinics, and clarity for the physicians, and look forward to talking to people here in the after session.
Thanks, Ken. Thank you very much. Michael, any thoughts you want to share?
Guess not.
Unless he's
muted. Muted. Sorry about that. Yeah, I just think it's fascinating how we're seeing these devices, especially the rhythm devices, have really been the furthest along, and seeing them mature and seeing the diagnostic accuracy and the discrimination between devices start to play out. I think it gets back to that issue of scale across the healthcare domains, and we need these devices to be incredibly good, like we're seeing, and very easy to get into the environments. We use a ton of Zio, and the number of patients that complain because they fell off and things like that. Those things keep getting better and better, and it's really it's a joy to see these things getting so much further advanced.
Terrific. All right. So next up, we're going to have Dr. Ledley tell us all about Endotronics. So why don't you take it away? You might be on mute.
And where is she?
She's there, but she's on mute.
Thank you. Sorry. Sorry. Now I'm unmuted, I hope. I'm sorry about that. So thank you for the invite, and I'm delighted to be here. So I'm Katrin Ledley. I'm the Chief Medical Officer at Endotronics. And so telemedicine is really here to stay, and particularly remote visits become more and more prevalent, as we also have seen at the UCSf data, which Dr. Bloom shared. And so we had before COVID 6% only of remote visits. Now we have 33%. However, to provide high quality remote care, you need an effective and user-friendly remote system. So Endotronics has developed such a best-in-class remote management technology, the Cordella system. And the Cordella system also includes a pulmonary artery pressure sensor, and it's really here truly to transform management of chronic heart failure with data-driven insight. Fundamentally, we target to improve lives of patients, heart failure patients, and the care provider who devotes their lives to delivering exceptional care of the patients. Currently, physicians often don't have the time and tools, importantly, to optimize patient medication as economic pressures force time and energies spent elsewhere. So as a result, we have great drugs for heart failure, great guidelines to follow, but only actually 1% are actually of patients receiving guideline-directed medical therapy. So our technology is not just a remote monitoring technology, it's really a remote heart failure management system. This is a big difference. And we're providing the tools and infrastructure to deliver the quality of care. So the commercially available system, the Cordella system, is designed to meet the needs of the patient and the clinician. So the patient at home daily does measure quick comprehensive vital signs and does a clinical assessment, and that will be sent to the clinicians. We have actually seen very good compliance, 95% compliance in patients, many of these patients more than 2 years actually on the system. So all this data gets securely transmitted to the clinician portal for proactive heart failure management to get the patients on GDMT. And it really allows a structured disease management to titrate and optimize medication. It's a scalable platform to streamline clinical workflow in all care settings, academic and in cardiology practices. Also importantly, it's EMR integratable. It captures time spent on the system and generates automatic reimbursement documentation for you. So both is very important to making this a profitable system. And for patients who are more in advanced heart failure and are in need of the advanced hemodynamic management, we offer then the pulmonary artery pressure sensor in addition to the Cordella system. And this is just adding a 20-second measurement with an easy-to-use handheld reader to their daily routine on the Cordella system. So this is a typically kind of a patient journey, if you will. So the system really provides ongoing knowledge of the patient's health status, timely optimization of medication, and building a long-term relationship actually between patient and clinician. And if we look at the next slide, so one big advantage is it really gives insight into the patient's health, like a comprehensive insight. And this is actual data from our first in human trial from a patient. And you can see here, so you see the pulmonary artery pressure, and in addition, you see weight and systolic blood pressure. You can also do heart rate. So we have several kind of vital signs you can look at the same time. So this patient, for example, had an increase in pulmonary artery pressure, and so the diuretics were added. Then this patient had an increase in pulmonary artery pressure, but also an increase in systolic blood pressure. So Entresto was added, and it's really nice to have all these vital signs for drugs like that to titrate up in a controlled manner, actually. And then this particular patient had a few weeks later another clinical episode, and that was a respiratory infection. And you can see the weight actually went down. Probably the patient didn't feel that great, and pulmonary artery pressure increased, and antibiotics were added. So this is really allows you truly to do precision medicine for heart failure patients, and really allows you to differential diagnosis and basically for the right medication changes at the right time and for the right reasons. So overall, hopefully this system is keeping patients healthier, out of the hospital, feeling better, and of course, making life much easier for the physicians as well. Thank you.
Excellent. This was great. We're now at the end of the this part of the session, which is having the 4 companies present. I think what everyone saw here was these are 4 amazing companies, and we picked these 4 companies because really for them, COVID did change everything. They're all seeing 4 to 5 years of growth in 1 year because of the need for their technology for clinicians to be able to monitor patients remotely. We're going to go into the third part of this of today, and you're going to see all of you are going to be broken up into 4 groups. Us moderators we're going to each get one of the panelists. So there'll be 4 of us, and it will be Michael, Paul, Daniel, and I. And you're going to be randomly put into one of the 4 groups. And this session, we're going to reduce just by a minute or 2 because we are running over and we're sensitive to everyone's time. We're then going to get together for just a few minutes to summarize. We're then going to end, and you're going to then have the option to go into each of the company's private Zoom sessions. With that, so let's just go to the next session.
Thanks. I've been painting it myself. I think we're still in the same room, or we're back in the main one. I can't tell, so everyone can hear us.
We're in the main one. Somebody asked about Epic. We have Epic interfaces from our Cardio Pro at, for instance, Cedars-Sinai, Cleveland Clinic, St. Luke's in Kansas City. It is not an easy proposition. It is not made easy, but it's doable.
If you can get it through Epic, you can get anything done. Epic Telehealth.
But do you know if it was orders or results in particular for interface types?
Yeah, I mean, we for our product, I can't speak for anybody else, we have a button on the Epic desktop. So just like next to the GE Muse, you can punch and you can order and you can get your reports and the summary reports come back in. It is a challenge because Epic installations are not homogeneous. Not everyone's on the same version or have the same features.
I live it, so thank you.
I have a son at Cedars-Sinai who's a physician on faculty, and I have a wife at Keck, and she's got Cerner, so I shared their pain.
You know, the integration is a big issue. You know, what Dave's describing, so Cedars is one of the most sophisticated Epic users with probably one of the most advanced installations and a big budget to do this stuff. That kind of side-by-side integration is great. It's real useful. Most places try to take the results, put the results in the right place, do some interaction. It is just really, really expensive and time-consuming and not the highest priority. So I agree. It's a big lift, and it's something you got to think about because you can't have a real scalable, deployable workflow unless you get somehow the record data needs to get into the record. So the decision or the data the decision came from, and it's got to get into a workflow. And there's a lot around that. That's usually that last mile that makes these things work in a proof of concept or work in a pilot, but then they don't scale and they go by the wayside. So kudos to the places that have gotten that done.
All right, we're all Michael, we're all coming back here from our respective sessions. And we want to do a little summarization before each of the companies have their own private Zoom sessions. And since Michael, you were talking and you're great at it, I want to know what you think, what you learned today. Tell me what was like, wow, I didn't think of that through.
Well, it confirms that there are just fantastic companies out there and that they get the issue of the integration and how important it is and the patient flow and the provider flow. It also confirms that there are still real barriers to making those things happen. I think what we're going to see is that this rapid, this was an abruption that's gotten us to these visits. There now needs to follow the technology getting in there in that same kind of, disruptive way. This would have taken years for us to gradually get there. We sat at, 1.5%, 1% video visits, which actually made us one of the biggest video visit users of Epic's technology at 1%. Now everyone is, in the double digits and way up there. So we're going to have to see that kind of disruption in how we're going to connect these technologies. I'm very pleased to see that the technologies are there. They're getting robust. They're thinking, the right way of how to move down the road. And we've got everything from simple recordings to complex analytics on recordings to pulmonary artery sensors. So the toolkit is there, which is what I was hoping for and seeing. It's going to be up to, the partnerships between the the vendors, and the sites to figure out how to actually get these things into these clinical environments that have no margin to really, spend to get them in there, and creative models of how they then, the providers and the manufacturers get paid for doing it. I don't know how that's going to play out. Okay.
Hey, Daniel, I want you to, what about you? What was the, what two or three tidbits did you pick up today?
Well, I love Dr. Blum's SaaS model. We need solutions, and the challenge with some of these elements is they're amazing technologies, but they're still somewhat siloed. And I think, I'm inspired to see all the things that are coming together. The trick now is how do you plug it into learning systems that can be personalized and unsiloed and can become part of a larger healthcare learning engine. It's always fun talking to Dr. Davis, who did the breakout, and being reminded that it's not just enough to invent the technology, but how do you get in the hands of the right academics and get the proof behind it, and the trust of the clinician and the patients, so it spreads and becomes applicable. So I think there's lots of lessons from all the startups and the folks here that are applicable. And as Paul's built for the 10 things to not make your startup fail, I wonder if maybe UCSF Health Club could come together with a playbook of things to help them succeed and harmonize on that.
Awesome. No, I think this is great. Well, I was going to ask a whole, we had a bunch of time for questions at the end, but I really want to respect everyone's time. It's about a few minutes of 5 right now. And we're pretty much done. And we're going to now allow you to basically either connect directly with any of the speakers, or as importantly, get into their Zoom sessions, which they've all published. So the Zoom sessions are being held by the 4 companies themselves. So look, on behalf of UCSF Health Hub and Daniel and Paul and Ralph, and thank you everyone for being here. This was a great second panel. We're going to be back in 2 weeks focusing on cancer oncology, and as our next topic. We wish everyone the best, and please go to these Zoom sessions. And thank you for being here.
Thanks, Mark.
Thank you.
Thanks for hosting this.
Thanks, everyone.
Mark, great job. Companies today, great presentations.
Great presentations.
Thank you all.
Thank you.
All right,
Thank you.
Thanks.
See you soon.